Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Darius Moshfeghi, who is director of the Retina Division at the Byers Eye Institute and professor of ophthalmology at the Stanford University School of Medicine. Darius, welcome back to United
Carmen, always a
States.
pleasure. It's been what, 30 years now that we've been having this conversation?
Yeah, well, there's always time for more information about retinopathy of prematurity. What we're going to talk today is an update on current diagnosis and treatment of ROP and some exciting new work that Darius is uh, starting. So,
Thank you.
diagnosis and treatment. What does the average retina doctor need to know?
What you need to know is you need to look at the baby. It's that simple. If we look at babies and you don't know what you're looking at, and it looks kind of like, oh, like there's some vascular tortuosity going on here, or I can actually call a stage. At that point, you should be phoning your friend and saying, hey, who does ROP that's pediatrics around here that can help me on this? And if you don't have someone like that, you have two options. You can think about intervening at that time point, or you can say, I want to see this baby again real soon. And it's not, you know, if you back it up, my career here has been based on using that concept of looking at the baby, and I do it through telemedicine. Okay. And in telemedicine, what we were kind of initially forced to do, and since has become the standard for telemedicine, is to use a mandated screening interval. Every baby, every week, or more often. That's not how we screen when we're screening in person, Carmen. There, we're informed by the Joint Statement Screening Guidelines, which uses data from both the early treatment retinopathy of prematurity study as well as the natural history arm of the cryo-ROP study, and they use findings-based screening intervals. So if you're zone 3 incomplete, you can see the baby in 3 weeks. If you're zone 1 incomplete, you should be seen in a week. And the only problem with that is that it assumes that you know 100% exactly what you're looking at. So if you're looking at an X22 weeker, 600 grammer on their first exam, and you think it's zone 3 incomplete, then you say follow up in 3 weeks. But the reality is, an infant like that has a 60 to 70% chance, just on those two pieces of data I gave you, of needing treatment compared to the overall field of 2%. Okay. And so if that baby comes back in 3 weeks, the baby's blind, and we as a community go and say, oh, it was bad disease. I'm here to tell you it's because you're not looking at the baby in a timely fashion. And so what we've done here at Stanford, and other people are doing it elsewhere, is we're taking the concept of the mandated screening interval and applying it to all of ROP. And as the baby gets older, the risk drops off. It's a perfect disease. It's a disease in a box, 12 weeks, basically from 30 weeks to about 42 weeks. Everything is going to happen that's going to determine how that baby sees for the next 85 years. Okay. And if you can get that baby to 42 weeks and never need treatment, you've taken them off the board and you've done that baby and society a lot of good. But your job during those 12 weeks is to be fairly paranoid. You shouldn't be trying to minimize the amount of time you're looking at that baby. You're trying to maximize the possibility that this infant can use all of their senses for the next 85 years.
What source do you use for your teleophthalmology?
We're like a camera source.
Yes.
So yeah, right now we're using two cameras. We're using 130-degree wide angle imaging. Currently, it's contact imaging. So it has several limitations. It requires pharmacologic dilation, which can cause instability of the infant systemically, either through, Brady's and desaturations, or it can cause hypertension, all of that. It can cause feeding intolerance for 4 to 6 hours. Fortunately, the incidence of these, even in what we call extremely low gestational age infants, is really low, on the order of 1 or 2%, but it's not zero, Carmen, and it can cause problems. So dilation is a problem. The second problem is that these wide angle imaging cameras, whether they're from Natus or Forest, each of which meet that criteria, which has been validated in prospective studies of identifying treatment warranted ROP, is that those 130-degree images are only possible if you have a contact on top of the eye. So it actually touches the eye. So that's a source of potential infection, and then potentially trauma could be induced, which is a theoretical concern, but there have been some reports of disease transmission, either conjunctivitis or RSV, from patient to patient via the camera. So the next area that we as a field really want is a non-contact, non-midriatic, wide-angle camera that gets us at least 130 degrees. And that's going to be your old stomping grounds with some kind of scanning laser, either OCT or a scanning laser ophthalmoscope technology. And now they're being able to put that stuff on chips. And I hope, fingers crossed here, in the next 24 months, we're going to see a camera with a cost of goods on the order of 5,000 bucks. And so at that point, it democratizes the access to telemedicine imaging. And if you really look at it for ROP, it's one of the last fields that we're not routinely imaging as a retina specialist in all of retina. And it just allows for objective longitudinal comparison. You can train an undergraduate student to tell change on images really quickly. And then the question is that change improvement or worsening? And that's another couple hours of training. But the reality is that the ability to discern change is something that humans are really good at. And it turns out AI is really good at it too. And that will be our next area. But to really supercharge this, we need non-contact, non-midriatic, wide angle because it eliminates the three risks. One is visualization risk, the other is systemic risk, and then the third is, infectious slash trauma risk.
Who puts the contact lens on the eye?
So currently, 95% of the time, it's a nurse or a neonatal nurse practitioner. 5
Mm.
to 10% of the time, it's the physician at the hospital. And, I'm currently covering 37 NICUs in the United States. So that's like over 3% of the NICUs and about 4% of the eligible babies. And these run anywhere from level 2 NICUs to level 4 NICUs where they offer ECMO transplantation, continuous cardiac transplant, and all of that. And it's really impressive how gradable the images are. I mean, a lot of people are going to say, well, we're waiting for the ideal image. The reality is, I like to tell my residents and fellows, MD stands for make do. Your job is to grade the image that comes to you, and you can't keep asking for a newer or a better or a prettier image. They don't want to go back and redilate the baby and do a stressful exam on the baby. So part of it's risk on for the grader. Can you figure out how to grade images that you're not comfortable with? And that comfort level is not a function always of the photographer skill set or the camera or the focus or the lighting or the artifact. Most of it, I would say at least 50% of it is physiologic. The eye has a hazy media. The eye is short. The eye grows 50% during the acute phase screening of retinopathy of prematurity. There's nothing like that we encounter in all of ophthalmology. It can grow from a 12 millimeter eye almost to 18 to 20 millimeters during that 12 to 15 week risk period. And so all of those things are impacting the optics of the camera. And a lot of that will fall away when we have a scanning thing, which, from your experience with OCT, you have a cataract, you got a media opacity. The OCT laser can go right through that most of the time. Same thing here with the haze, and you can get good details. Pete Campbell's group has been developing an OCT along with Paul Chan out of UIC and Portland, where they can basically give you the entire vascularized retina in one image. Okay, anywhere from 100,000 scans per second, whatever the frequency is on this, and the detail is stunning. I don't really care about the OCT aspect of it. I don't want to add that confusion to our grading paradigm today. Okay. I just want to use the on phos view, which is, if you can give me that non-contact, non-mid in 3 seconds, basically aura to aura with one view, I'll take it. It's a huge victory for our field.
What do you do when there's a treatable lesion?
So it's back to our things that you brought to the table. It's Avastin. So July 2005, you guys introduced Avastin, and in December of 2005, both in Portugal and out of Mexico City, we got the first case reports on the use of Avastin. And the original dose is still the best, 0.625 milligrams. It gives you an immediate response in 24 to 48 hours. You'll see plus regression, depending on the amount of stage. Stage may go away in 7 to 10 days. It can go away as quick as 24 to 36 hours. Just depends on where you are in the disease process. Um, a lot of people have been concerned. There was a study that came out of Hospital for Sick Children's by Morin or Morin and colleagues that showed that there was increased risk of adverse neural developmental outcomes in the bevacizumab treated group compared to the laser treated group. But the reality was it was an uncontrolled study from the perspective of all the small sick babies got bevacizumab, all the large, bigger baby, healthier babies got laser. And it turns out that small sick babies independently are at risk for adverse neurodevelopmental outcomes. And I like to point out that one of the worst adverse neurodevelopmental outcomes is blindness. Okay. And we can almost 100% take that off the table by timely screening and then timely intervention. The way I like to view it is that bevacizumab today is so effective that if you do not see a response in 36 hours, the logical conclusion that you can make is that the drug was not delivered inside the eye. It dripped out before it got in.
Mhm.
And it's such a tiny volume. It's on the order of a tenth of a tear, 0.025 mLs, that as soon as you turn the needle upside down, you can just see it, the syringe upside down, you can see it dripping out. But once it gets in there, and in fact, I believe, I don't want to stick needles in babies' eyes that often. If you can do the job once, that's my philosophy. But if you look at that baby again in 48 hours and they still have active disease, that's an indication to go back and inject right then and there because the assumption is you didn't get it in the eye. And so then the question is, how do we follow these babies? So currently, at most major academic centers, it's a bevacizumab first or anti-VEGF first world. And there's reasons for that. It's not because we all love bevacizumab. It's because um, we have really small, sick babies. Okay. And the closer you are to the center of the bullseye, basically zone one, if all of your retina's in zone one, you can win the battle by inducing regression with laser, but you'll get anterior segment ischemia and you'll lose the war. Okay. And that's happened to all of us at one point or another. The amount of laser that is necessary to treat a truly zone one eye is more than sufficient to induce the devastating sequela of anterior segment ischemia, which made all of us look very carefully at, switching over to anti-VEGF therapy. And since the majority of the babies we're looking at are these really what we call micro nanos or micro preemies or nano preemies, babies between 24 and 26 weeks, 600 to 799 grams, or less than 24 weeks, less than 600 grams. Those are anywhere from 30 to 35% intervention rate or 60 to 65% intervention rate, compared to 2% for the entire eligible ROP screening population. And so we, at these major academic centers, have these really small, sick babies disproportionately represented in our practices, which means that we're using anti-VEGF strategy first. And then later on, if they don't fully vascularize, there's a raging debate in the field. Should we treat the peripheral avascular retina? And then if we're treating, what are we treating for? I believe, yes, we should treat the peripheral avascular retina. And I think it's to shut down the ongoing VEGF drive. Okay. Other people say, yes, we should treat it, but only to in a retinopexy sort of standard. So we know that these babies later on will be predisposed to peripheral retinal degeneration. Frankly, I'm not convinced that circumferential retinopexy is going to be an antidote for that problem unless you're talking a hereditary myopia such as type 1 sticklers, where it's been demonstrably proven in the Cambridge Eye study using, cryoretinopexy. Here, I'm less concerned, but I have seen reactivation. It's been reported in the literature at 1 year, 2 years, 3 years, 4 years. I've heard of a case, 6 years reactivation down in Brazil. And what I always tell people, it's bad that you're blind from birth. It's really a tragedy if a child has vision and then they lose it because we weren't following them and they reactivated with attractional retinopathy. So my own personal um, experience and preference is to go in there and treat the avascular retina if they're within 2 disc diameters of the ora serrata. And I would say about 50% of the field believes that way. Now, some very smart, talented people, Nina Baricol, Domenico Lepore, take the opposite position. I respect their opinion, and I know they're following those patients closely. And so we'll find out over time.
Mhm. How many treatments does the average baby have? One?
Yeah. So if you're doing it right, okay, and you deliver it, you should get one treatment that should get you to the end. Now, um, I would say we see reactivation as kind of like it's a nebulous concept. Like I treat all babies for peripheral avascular retina 60 weeks. Now, why 60 weeks? In the state of California, if you've been discharged home and you come back in for general anesthesia and you're under 60 weeks, you have to spend the night in the hospital. Okay. But if you're over 60 weeks, you can go home after anesthesia clears you, which is why I don't bring them back in until 60 and 0 7 weeks because the mom or the dad will hunt me down and yell at me if they have to spend the night in the hospital if they just got discharged. Okay.
Mhm.
And so that rule tends to vary by state. Some people will do peripheral avascular retina laser before the baby gets discharged from the hospital in order to minimize the burden on the family. Other people will never do it and they'll just continue to observe it. Tahiri's group out of, again, Hospital for Sick Children, they just had a kind of grand rounds for the pediatric retina community about 10 days ago with Matt Tracy leading it. And what they showed is, you can follow a lot of these babies a long time and they will continue to vascularly mature. But they're doing aggressive follow-up and they're doing sequential fluorescein angiography. And it's worth noting, Carmen, that prior to 2015, there were no documented cases of peripheral avascular retina. So we went 10 years for treating ROP, and everybody just assumed that the retina was 100% vascularized. And when I was looking at my data, I was like, dang, I suck at this because like 95% of them are not getting vascularized. And then I had the epiphany when I read Lepare's study on angiographic vascular abnormalities after anti-VEGF that I realized that I was routinely getting fluorescein and it was showing the peripheral avascular retina. When you look in there, it looks 100% vascularized. You need the fluorescein routinely to tell you it isn't. And they didn't highlight in their paper. They were just showing you the vascular looping and the shunting and the telangiectasias and the duplications and all of that. Um, but clearly in every image, you could see the peripheral avascular retina also. And I was like, that is the highlight to me. And even if you go back to Helen Mintz-Hintner's paper from the Beat Rop in New England Journal, on the figure where it shows laser versus bevacizumab, the bevacizumab paper has peripheral avascular retina in it. They just didn't highlight it. So it's a problem, and we as a community are continuing to deal with it. Now, the best way to deal with it is to not have to treat the baby, which is what we're doing with the prevention trials. I'm working with Nobu and his company, Felix, Feliqs, and they're using an antioxidant treatment strategy, prevention strategy. And the problem historically with prevention strategies is that they've led to increased mortality for the infant, which is not a good outcome, right? Vitamin E, when it came out, it was being used since vitamins were not regulated by the FDA. E-ferrol came out in the mid 80s, and people had known that vitamin E has antioxidant properties. And so they started using it for the treatment of ROP based on some papers that come out, including one by Helen in the New England Journal of Medicine, which showed that the group that got exposure to vitamin E were less likely to develop advanced ROP. They were using different terminology at that time, not the international classification, and the numbers were small, but people started using eferral offline, and unfortunately, 37 infants died. Okay, and we've seen increased incidence of adverse outcomes, including mortality, including with the support trial when they were doing modulation of oxygen. Turns out we need oxygen to survive, but if you lower oxygen and tightly control it, you can have really good ROP adverse outcomes improvement. And so when we are looking at doing something systemically in a preterm infant, the concern always is that you're going to have an unintended consequence. Felix's approach is to use a lipid anti-peroxidase strategy that will be administered in the infants prior to um, the screening period. So between the 26 and 30 weeks, and we start screening at 31 weeks. Um, and it's anticipated based on preclinical work in mice that you can have a beneficial effect both in the amount of neovascularization and the amount of oxidation that's going on in these eyes, um, and that this would lead to either a decreased total amount of ROP or a prevention of ROP to begin with. We all know that nothing is 100% successful, so we'll still have to continue screening these infants. But that study is beginning shortly, phase 1, 18 patients down in Austin, Texas. So pretty excited about that. It's the first trial for prevention in a long time, and it's one of the few ongoing therapeutic sort of trials in ROP at this moment.
It's easy to identify the high-risk babies.
Oh yeah, so we know which ones. And in that trial, basically it's small babies with short gestation. And you don't want the super small ones because they tend to have higher morbidity. You don't want to have that more and mortality. So you don't want that as part of your confusion matrix when you're analyzing the data. Did the baby not make it because of they were small sick, or did they not make it because of what you did? So what you want to do is get the kind of Goldilocks baby, which is the micro babies. So between 24 and 26 weeks and 600 and 800 grams. And we know that they're going to intervene at 30% rate. Even in a phase 1 trial, if you showed even you were only getting a 10% rate of intervention, that'd be a 2/3 reduction. That'd be a huge win.
Oh, this is exciting.
It's super exciting for us, and we have a way of documenting it photographically now. So before it was everything was just written down. Even on we're currently informed of treatment intervention based on the ETROP study, the pharmacologic studies, including Beat Rop, Rainbow, Firefly, and Butterfly. I ran the Butterfly trial, all had some form of photographic documentation, but the intervention thresholds are based on 25-year-old intervention data that was not objectively documented on photographs routinely. And that was pre the development of, well, pre-use of RetCam for ROP.
Thanks so much for reviewing retinopathy of prematurity with us, Darius.
Carmen, thank you for taking the time. It's always a pleasure seeing you.
Thank you.